So today we are going to look at classification systems within clinical psychology. The aim of today's lesson is we're going to have a look at the two classification systems which are used to diagnose patients, which are DSM and the ICD, so the Diagnostic Statistical Manual and the International Classification of Diseases. So, just generally talking about diagnosis, it's a very difficult task to diagnose patients with a mental health problem because so many different things have to be taken into consideration. And in 1948, the World Health Organization compiled a list of mental disorders in the ICD. 4 years later, the Americans released the DSM, the Diagnostic Statistical Manual, and both the DSM and the ICD have been revised many times, really, because they need to be updated. Symptoms change, and the Diagnostic Statistical Manuals also need to be changed accordingly. And diagnosis is really important because it's the key thing really for any treatment. So if we're not able to diagnose somebody correctly, then obviously the treatment is not going to be correct either. So both of these systems are used widely around the world. Some do argue that there are reliability and validity problems with these systems, which we're going to have a look at in this presentation. Mental health disorders do not always have obvious physical symptoms. So, we wouldn't expect to have a look in your brain and something's different physically, which does make diagnosis a lot more difficult because interpretation of symptoms is also something that does affect the clinician's judgment. Before we really go into the two systems, there's two important words that we need to understand. So we've got reliability and the validity of diagnosis. When we say reliability, what we're talking about is how likely the clinicians are to agree on the same diagnosis. And it refers to consistency, which is really important in diagnosing, because if two clinicians do arrive at different conclusions about the same patient, then there's obviously a reliability issue there. Validity of diagnosis is the extent to which the diagnosis actually reflects the underlying cause of the disorder. And it can be argued that for a diagnosis to be made correctly, it should also be predictive. In other words, you should be able to predict the patient's treatment as well. For example, if we are diagnosing a schizophrenic patient by hallucinations, delusions, which is often caused by high levels of dopamine neurotransmitter in the brain, then we must make sure that our treatment also reflects that cause. And generally antipsychotic medication does work by changing neurotransmitter levels. So this is what we mean by the validity of diagnosis. There are also different types of validity that you do need to be aware of in clinical psychology. Firstly, you've got concurrent validity, and this is where you compare the different systems to see if they agree. So you would compare the DSM system to the ICD system to see if there's an agreement. And obviously, if there is a greater agreement, then we can argue that it's a lot more valid. You've also got something called etiological validity. Now, etiology is all to do with the causes of the disorder. So if the cause of the disorder matches the patient's history and symptoms, for example, if there's a genetic component to a patient's schizophrenia, then we could argue that this is more valid because it's more likely that they are suffering from schizophrenia if there is a genetic history of inheritance of schizophrenia. You've also got predictive validity. if the results, which I've touched on already, if the results from the diagnosis can be used to predict the patient's behaviour. For example, antidepressant medication works within 6 to 8 weeks of use because it takes a while for the levels of neurotransmitters in the brain to change. Okay, so that's predictive validity, being able to predict the patient's behaviour based on your diagnosis. Okay, so the first system we're going to talk about is the ICD, the International Classification System. And this originates from 1893 and includes both physical and psychological disorders. So it's not just mental health issues, but it's also physical disorders. And it has been revised several times to update the system. And the whole point of updating a system really is to make sure it is more reliable and more valid. The ICD has been used internationally, so it is cross-cultural, and it has been used in lots of different countries, where symptoms can also and diagnosis can be also compared across different cultures. The ICD system does contain a section F, which is specific to mental health disorders and group disorders. Into families, for example, mood disorders or affective disorders includes things like depression and bipolar disorders. These are then coded by a digit which represents the family of the health disorder and also the specific disorder itself. So, for example, F could be to do with mood disorders, the code, but then each individual specific disorder would be coded differently by a number. So F32 would be depression, or F31 would be bipolar, and so on. After that has been done, the digits been assigned, then clinicians will attach a decimal point to that digit, and the decimal point really shows the severity of the disorder. So, for example, F32.0 would be considered mild depression, okay, whereas F32.67 might be a little bit more severe. And the whole point really of using these codes is to index medical records, and to just really make it a bit more easier for clinicians to convey that in a more systematic way. It does also enable clinicians to make a diagnosis, such as looking at specific symptoms and severity and the duration. So it is important. This is why they use these coding systems in the ICD. The information that is gained from the diagnosis can be used to conduct a clinical interview with the patient later on to get some additional or further information. Now, there are obviously reliability and validity issues with diagnostic systems, even though they are being improved and updated all the time. In 2006, Alexandra Poniatowski found that when looking at the proportion of people that retain the same diagnosis when they are assessed again, actually increased by 26% in schizophrenia. So what that's saying is the first time they tested or diagnosed people, then the percentage was very low. So then the second time they were reassessed, those patients, they did reach a diagnosis with an increase of 26% in patients. So again, that does show that we are kind of getting better at detecting and diagnosing. There was also a 16% increase in mood disorders diagnosis and 8% for anxiety. So what all this data really shows is that we are slowly improving our reliability with these systems. Another study in 2004, Gangelzi arranged for 2 researchers to jointly assess patients with psychosomatic symptoms, and those patients showed very high agreement rates, showing good interrelator reliability. In other words, both of the researchers did reach the same conclusion for the patients. Validity, Mason 1997 found that the diagnosis of schizophrenia using ICD does have good predictive validity. So, there have been many studies which have been for and against in terms of validity, but this one is obviously a strength. The World Health Organization has conducted a survey of clinicians and found that they do show a preference for simplicity and flexibility. Therefore, clinicians are pretty cautious about diagnosing because they understand the implications if a false diagnosis is made. Therefore, this does improve the validity if the clinicians are that extra little bit careful and cautious. So that was the ICD. Another system is the DSM, so the Diagnostic Statistical Manual, which was published in 2013, version 5. And again, it's been revised so many times. And it's divided into 3 main sections. So the first section looks at guidance and really shows you how to use the diagnostic system. The second section really gives a description of the disorders with some categories. And then the third includes actual suggestions about new disorders which might require further investigation, because often clinicians might be diagnosing a patient, but then they may come across a very random or unusual symptom which they've never seen or heard before. Therefore, this sort of looks at potential investigations that can be carried out into these areas. The DSM, so clinicians largely gain the data via unstructured interviews, and they may use obviously self-report methods such as a questionnaire called the Beck Depression Inventory. And clinicians will start by really ruling out certain disorders that do not match the symptoms. So rather than ticking a box saying yes, you have this, and you have this, they will look at what they actually don't have in terms of almost like shortlisting a list of disorders which could be potentials. It's important to observe the consistency also over time, so looking at how often those symptoms do occur, and that again enables the clinician to give a more reliable diagnosis. The DSM system itself does group disorders into families with similar disorders in one category, because obviously the symptoms, if they are similar, then they will be grouped together. And the latest is version axis consists of 5 axes. Axis 1 consists of mental disorders such as schizophrenia. Axis 2 is personality disorders. Axis 3 is medical conditions such as physical disorders. Axis 4 looks at psychosocial disorders, so environmental triggers really to a person's disorders, which could be like bereavement, job loss, separation, etc. And axis 5 is something called a global assessment functioning of the person, and really this looks at assigning a score out of 100 on that person's general functioning in the world, so their ability to wash, dress themselves, socialise, maintain a job, etc. And the clinician uses all of this information to conduct a clinical interview and to obviously follow that up with more questioning in an interview. The DSM reliability ratio 2013 showed great agreement between clinicians on a range of disorders. For example, the rate for post-traumatic stress disorder was 0.6279. So again, that shows pretty good agreement between clinicians. However, one problem with the diagnosis has been that agreement levels of DSM were quite low when originally it sort of was published. And agreement rates of 0.2 to 0.4 were actually considered acceptable. So that's quite low. And to sort of use that as a method of saying yes, it's reliable, it's a bit questionable, isn't it? Because 0.2 is not very high at all. Kim Cohen 2005 on validity showed good validity of DSM conduct disorders. Furthermore, predictability was also established as 5-year-olds with conduct disorder were more likely to display behavioural difficulties when they were aged 7. So again, going back to the idea of that predictive validity, you should be able to diagnose somebody and then be able to predict their behavior, which shows the validity of your diagnosis was high. And a weakness is it does lack validity, because many clinicians do argue that diagnosis doesn't tell us much about the cause of the disorder. So yeah, it might tell us what's present, but it doesn't really tell us the origin and where that disorder started from. Again, there's a few more of the studies here on this page, which I want you to have a read of and see if you can organise into reliability or validity and what they show. Some further points really on diagnosis. So there's a few other factors which could also affect how reliable or valid a diagnosis would be. And one of them is patient factors themselves, because if a patient is mentally unable to really describe their own or conscious awareness, then that can be very difficult, because they may often give inaccurate information, maybe exaggerated information, or they may even have problems with memory or feel embarrassed to talk about it. So they may not report all the symptoms, which again can lead to unreliability. Clinician factors can also impact the diagnosis, as when clinicians do conduct an interview, sometimes they can sort of use their own subjective judgments and be sort of swayed on their own experiences and their own sort of techniques and training. So that can sort of bias their views and lead them into subjective interpretations, which can be a problem with validity. They may show implicit bias, which is related to the previous point, when they do let their personal judgments affect the diagnosis. So for example, a clinician may be more likely to diagnose depression in a female patient compared to a male patient because of its prevalence already in female patients. Disorders can also be comorbid, which makes it very difficult to diagnose. So you may get a sort of overlap of two different disorders or symptoms that are not really part of a certain disorder. So again, all of these points really make a diagnosis very difficult, and it's not something that is very easy to do.